So let's move on to polyps of intestine. So the polyps can either be non-neoplastic polyps or neoplastic polyps. So non-neoplastic polyps, let's see about that first. We have various categories: inflammatory polyps, hyperplastic polyps, and hamartomatous polyps. So inflammatory polyps are just that they are associated with some inflammatory lesions. So the best example will be solitary rectal ulcer syndrome. So usually it appears at the rectum and will appear in young adults around 20 to 30 years of age group. And here what is the defect is actually during defecation. So chronic constipating patients, when they defecate, they strain a lot. So that is going to cause ulceration of the rectal mucosa, and then it will prolapse. So the rectal mucosal prolapse will be there. So due to this chronic inflammation, so there is going to be ulceration of the rectal mucosa. Along with that, there will be cystically dilated rectal glands. In hyperplastic polyp, it is going to be seen mostly in elderly age group around 6th to 7th decade. So here again, the most common location is rectosigmoid only. Here actually it is not a neoplastic polyp, right? So what happens here is there is going to be delayed shedding. So the turnover is not proper. So there is accumulation of this cells. So that is why it is going to appear like a polyp. So the classical appearance of a hyperplastic polyp will be the serrations. So can you see here, this normal gland architecture will be like this. So uniform circle will be there in the center, while here if you see, it is all having some kind of serrations. So this kind of serrated appearance is called as a serrated lesion. So why is it important? I'll tell you in a while. So just remember, hyperplastic polyp can have a serrated configuration, while the serrations are do not extend to the entire length of the crypt. Okay, so there will be crowding of the cells. That is the reason why there is the polyp formation here. And all the cells are mature intestinal cells with presence of goblet cells. Let's see about the various hamartomatous polyps. So the first hamartomatous polyp will be a juvenile polyp. As the name suggests, it is going to occur in young children, usually less than 5 years of age group, and they'll have a classical history of rectal bleeding. So most commonly this polyp occurs in the rectum, and they'll have rectal bleed, and it is associated with mutations like SMAD4 and BMPR1A. So this is associated with a syndrome called as juvenile polyposis syndrome, which is an autosomal dominant condition. And this condition, when juvenile polyps occur in this syndrome, it is going to be pre-neoplastic. As such, they are not pre-neoplastic. Okay. So how does it look like? That is going to have some ulceration of the rectal mucosa. So here you see the intact mucosa. Here it is all ulcerated. It's not covered. And this dilated, cystically dilated glands of the rectum is also seen. So along with that, you can have lots of inflammatory cells. So these are all the inflammatory cells. So these three components form the classical description of a juvenile polyp. Next hamartomatous polyp will be a Peutz-Jeghers polyp. So this one we'll all be familiar about. So very favorite question. So it is also an autosomal dominant condition caused due to STK11 and LKB1 mutation. And here the patients are going to have intestinal polyps. Along with that, they'll have skin pigmentation, especially around the lips, nose, and around the genital region. So perioral skin pigmentation will be there. This image has been given in MCQs. So perioral hyperpigmentation along with multiple hamartomatous polyp history is given, and they'll ask about the mutation. So it is STK11 or LKB1 mutation. And the classical image of the microscopic image of a PJ polyp is, it is going to be an arborizing polyp, meaning the arborizing in the sense it is going to look like a tree. So tree-like a polyp appearance will be there, and the core of the tree is going to be formed by smooth muscle. So smooth muscle, this is all the smooth muscle which has gone and formed the core of the polyp. Okay, so this arborizing polyp, in which the core of the polyp is formed with the branching smooth muscle. This is the spotter kind of a diagnosis, most important, because of this this feature is seen only in PJ polyp. So when they ask about this, they are mentioning about PJ polyp. Remember that. And this polyp, when PJ polyp is there, it is going to be associated with various other cancers. So it has an increased risk of developing GI cancers, pancreatic cancers, lung, genital, thyroid, gonadal, and breast cancer. So various other cancers risk is also associated with PJ polyp. Then we have Cowden syndrome or Banyan-Ruvalcaba and Relay syndrome. So Banyan-Ruvalcaba Relay syndrome and Cowden syndrome, both of which is going to have the P10 mutation. So P10 is going to be present on chromosome 10p. So remember, 10 is there, P is there. So 10p. Okay, and then Cowden syndrome also has some den in it. Like it sounds like 10, right? So Cowden syndrome 10p mutation. Okay, which is involving the P10 mutation. Okay, here we are going to have multiple hamartomatous polyps. Along with that, we will also have other skin and neck cell tumors, some ganglioneuromas and lipomas. And as such, there is not going to be any risk of GI cancers. Okay, doesn't have risk for turning into GI malignancy, but it has risk of developing into other malignancies like thyroid and breast usually. Okay, and chronic Canada syndrome, it is a non-hereditary kind of a syndrome occurring in elderly age group, 50 years above. And here it is going to be associated with hamartomatous polyps and various skin associated conditions. Like the patient will have nail atrophy, hair loss, and then they'll have skin pigmentation along with cachexia and anemia. So when they are mentioning some skin related changes along with hamartomatous polyp, it is the chronic Canada syndrome. And remember, it is a non-hereditary syndrome, so there is no mutation associated. And the last hamartomatous polyp will be tuberous sclerosis. Tuberous sclerosis we had seen n number of times now. So here mutations associated with TSC1 and TSC2, which is hamartin and tuberin mutations. So we are going to have various hamartomatous polyps. Other than that, angiofibromas, then renal angiomyolipoma, renal angiomyolipoma we had, rhabdomyoma also we discussed. Then I told about astrocytoma, one type of astrocytoma associated with tuberous sclerosis. So various kind of lesions are associated with tuberous sclerosis. So in polyps, these non-neoplastic conditions are also important. Then we'll move on to the neoplastic polyps. So under neoplastic polyps, as the name suggests, they are going to be precursors to adenocarcinoma. We have three main types of adenomatous polyps, which are tubular adenoma, tubulovillous adenoma, and villous adenoma. Out of which, villous adenoma has the maximum risk for converting into adenocarcinoma. So as the name suggests, tubular adenoma, in the polyp, you are going to have tubular gland formation. So, tubular in the sense it is going to appear round. So, tubular gland formation is going to be there, while tubulovillous is going to be both tubular and villous kind of an architecture is going to be there. While in villous, it is all villous kind of an architecture. So, it is all showing lots of villous, right? Long villous finger-like projections are there. So, this is a villous adenoma. So, the next type of neoplastic polyp is a sessile serrated lesions. Initially, it was called as sessile serrated adenoma, and now it is called as sessile serrated lesions. Okay. So, these again, do you remember in non-neoplastic polyp, I mentioned about hyperplastic polyp, which also had a serrated architecture. So, that is why it is important to distinguish it from sessile serrated lesion, which is a pre-neoplastic polyp. So, here in sessile serrated lesions, here also you are going to have this serrated kind of an architecture only, but the serrations are going to involve the entire length. Okay, rather than in hyperplastic at all, it's not going to be present on the entire length. While in sessile serrated polyps, here it is going to involve the entire length. Serrations are going to involve the entire length, and it is involving the crypt also. And one other feature of this will be, this polyp can have lateral extensions like this. The crypt is going to have a lateral extension like a boot. So, this is called as an anchor shaped or a boot shaped polyp also. So, the base of this crypt is going to have this lateral extensions. So, this is a classical feature of SSLs. And this sessile serrated lesions, and compared to adenomatous polyps like these villous, tubulovillous and tubular adenomas, they are going to have a different pathway in which they are going to transform into a carcinoma. That I'll discuss when I'm discussing carcinoma. Okay. So, other neoplastic polyps are associated with familial adenomatous polyposis syndrome. So, FAP syndrome we usually call it. This is associated with APC mutation. APC gene is going to be present on chromosome 5q21. Okay. So, APC I already mentioned is associated with the beta-catenin pathway. So, APC beta-catenin pathway is the very first hit which happens in the colon cancer. So, these patients, FAP patients, it's an autosomal dominant condition here. When they have this APC mutation, they'll have lots of polyps, like literally 100 plus polyps will be present on the intestine. So, even the criteria for calling it as FAP is you should have a minimum of 100 polyps. Just imagine. So, it is usually a adolescent kind of a kid who is having this 100 plus polyps. Along with, and these polyps are usually adenomatous polyps which can convert into adenocarcinoma. So, there is going to be 100% of risk of conversion into adenocarcinoma, and by the age of 30 itself. Okay. So, colon carcinoma at the age of 30, just imagine. So, this kind of FAP has a very high risk for conversion into adenocarcinoma. And FAP has been classified into 3 types based on the presentation. Even though the APC mutation is common for all of this, it is going to, based on the presentation, we have 3 syndromes. So first one was classical FAP, in which you are having this polyps associated with retinal pigment epithelium hypertrophy. Then we have Turcot syndrome. Turcot syndrome here is the same, polyps will be there. Along with that, you are going to have brain tumors. So brain tumors like medulloblastoma and glioblastoma. If you remember, in medulloblastoma, I was mentioning in the molecular classification of medulloblastoma, there is a WNT or beta-catenin pathway, right? So WNT beta-catenin activated. So WNT is related to APC, right? So that is why here also FAP is related with APC. So that is why Turcot syndrome is coming. So whenever you read, link it and read so that you will not get confused. The third syndrome of FAP will be Gardner syndrome. Here again, along with the polyps, you are going to have lots of fibromas, osteomas, abnormal dentition, and then lots of epidermal cysts. Okay, so these 3 syndromes are part of the familial adenomatous polyposis syndrome. Now we had seen about the various polyps. So polyps again are very important questions for MCQs.